Jabalpur, and this is our journal club again. And she is Dr. Disha Paryani, and she is a MS OBGY and DNB FMAS, and she is the new fellow joined us. And as we do with our fellows, that every 15th day we do a journal club with taking some topics from fertility, sterility, or prenatal diagnosis. Or Ashita, my previous fellow, she is about to join on a day 3 or day 5 transfer, Blastocyst transfer, which is very recently come in June 2025 Fertility Sterility Journal. So I request Dr. Disha, this is her first journal club in my institution. She is a practicing gynecologist, and she does endoscopic, laparoscopic hysterectomy, and a very good laparoscopic surgeon also, but with training for IVF and training for all embryology, ultrasound and everything. She has joined us. I request Disha, please introduce yourself and go ahead with your.
Thank you so much, sir. I am Dr. Disha Paryani from Jabalpur. I am doing laparoscopic and endoscopic surgeries, and I have joined sir to learn IVF, ultrasound and embryology. Today we are going to discuss steroids and their role in contraceptives. So we begin our topic, and we will begin with exploring steroids of oral contraceptive pills. So first we will understand what is steroidogenesis. Basically, the parent molecule of steroidogenesis is cholesterol, and this cholesterol is absorbed from our intestine through lipoproteins into the blood, and with the help of lipoproteins, it is transported in the form of VLDL, LDL, HDL, and it goes to the target organs, this adrenal glands and the ovary. Now, the parent molecule, that is cholesterol, that is a C27 molecule having 27 of this molecule and undergoes by the enzyme known as desmolase, and it will get converted into a C21 compound, that is pregnenolone. Now, pregnenolone has double bond between these 5 and 6. It is a weak molecule, so it is a delta 5 molecule. This pregnenolone will eventually enter into the delta 5 pathway, and it will get converted into 17-hydroxypregnenolone, that is by the addition of hydroxylase and molecule OH at the 17th position, and it will form 17-hydroxypregnenolone. From this,
you take this one.
just a second. From this 17-hydroxypregnenolone, there will be removal or cleavage of 2 carbon atoms, and this will get converted from C21 to C19 compound. And this C19 compound is dehydroepiandrosterone. Dehydroepiandrosterone will again get converted into androstenedione, which has 2 double bond O, 2 times double bond O.
I am interrupting you.
Yes.
Basically this topic we are discussing this topic to understand the steroid, and with that understanding of the steroid, why we are studying this. That is very
okay. So I'll explain in this way.
You have to teach the people, otherwise it will be very monotonous and
So a cholesterol, our parent molecule, will come into the ovary. It will enter the theca cells through blood vessels, because theca has blood vessels. Now cholesterol has 27 carbon atoms. So we start from this 1, 2, 3, 4, 5, and then it goes like 1 bond is here, 1 carbon atom is here, and then this is the side chain. So this is total 27 carbon atoms. Now from this 27 carbon atoms, there will be cleavage of this side chain. So this will go away with the help of desmolase enzyme. So instead this will go away, and there will be addition of 2 this bond, double bond loop. So it will form pregnenolone, and there is this double bond is between 5 and 6. So this is delta 5 compound pregnenolone. Now it will enter into either delta 5 pathway or it will enter into delta 4 pathway. Usually in pre-ovulatory stages, the compound enters into delta 5 pathways only. So pregnenolone will then get converted into 17-hydroxypregnenolone with the help of enzyme hydroxylase, alpha hydroxylase. That is, there is addition of this OH bond at this 17th position. So it will become 17-hydroxypregnenolone. And then there will be removal of 2 carbon atoms. So it will get converted from a C21 compound, which is this one. This is the 21 carbon compound. So this is also 21. From here it will get converted to 19 carbon compound from with the help of desmolase enzyme. So these 2 carbons will go away and it will become a 19 carbon compound. This 19 carbon compound is, this ring is an androgen ring. So this will become a 19 carbon compound. This is known as dihydroxyepiandrosterone. From here, this is delta 5 because the bond is between 5th and 6th position. From here, it will get converted into, this molecule will then seep into the granulosa cells, and from there it will get converted to androstenedione in the granulosa cell. So when it gets converted from this to this double bond will change from 5 to 6 to 4 to 5. So it will become a delta 4 compound, and then there will be 2 ketone groups, one at the 17th position and one at the 3rd position. Now this will, in the granulosa cells, granulosa cells have aromatase enzyme. So they will convert androgens to estrogen. So androstenedione will get converted to testosterone first by addition of a hydrogen OH bond at the 17th position, but at the beta position, that is above the spatial plane. Here it was alpha and this is beta. So it will get converted to testosterone, and this testosterone will undergo aromatization and it will get converted to estradiol. Estradiol means 2OH because it is diol. So there will be 2 OH bonds, one at the 3rd position, one at the 17th position. Now this androstenedione might as such can get aromatized and it will form estrone. Means there is one ketone. So one ketone at 17th position. So this is in short steroidogenesis. Now after ovulation, then there are blood vessels which start entering the ruptured follicle. And that's why the cycle then shifts to delta 4 pathway. And at that time, from pregnenolone, there is lot of cholesterol and cholesterol entering the granulosa cells through the blood vessels. And then this delta 4 pathway starts. That is, this pregnenolone will start getting converted to progesterone. Now progesterone is a delta 4 compound. So that is why from 5 to 6 bond will shift to 4 to 5. And there is ONE, so one ketone will get added. So here at 3rd position, ketone group will come. Now this is C21. This is also C21. Here only if there is again OH bond addition and at the alpha spatial plane, it will become 17-hydroxyprogesterone. And then there will be removal of 2 carbon atoms, and then it will become a 19 carbon compound, that is androstenedione. So this happens in the post-ovulatory phase, the delta 4 pathway. So this is how we understand how estradiol is formed in the ovary from the granulosa cells. So next we will see how we use these steroids in oral contraceptive pills. In oral contraceptive pills, how we use. Now in oral contraceptive pills, we have to take a pill which is active orally. So we have 2 components. One is estrogen and another is a progesterone component. Now estrogen is used in the form of ethinyl estradiol. Ethinyl estradiol means that there is addition of an ethinyl bond at the 17th position. So that will make it orally active. So we use ethinyl estradiol. Another compound which we use is progesterone. Now we use in pharmacology, the testosterone molecule is used with an addition of ethinyl bond at the 17th position. So it will become ethisterone, And when there is removal of the 19th carbon atom, then it will become 19 norethisternol.
So can you show this diagram in the next slide which you have prepared?
Yes.
Now explain.
See, this is testosterone. Now here, if there is, we add one ethinyl bond here at the 17th position, so it will become ethesterone. And when we remove the 19th carbon atom from here, like this is removed, then it will become norethindron. 19 norethindron compounds. So this is orally active, and it has a good potency also.
Of progesteronic activity.
And progesterone.
Although you started it with androgen, that is testosterone.
And one carbon also we removed, so it became an estrone ring, but it has a good progesterogenic activity.
No, it is not an estrone ring. Go behind. It is. Why it is not estrone? Because whenever there is a estrone, then now. Whenever there is a estrone, there will be aromatization, there will be three double bond. But if you see this removal of 19th carbon atom, although it becomes C18, it is not estrone nucleus. So it is still a delta 4 compound, which is of testosterone derivative, but you removed it and it changes its characteristic and becomes progesterogenic. But it never relinquishes its androgenic activity. So
it is a progesterone with androgenic activity.
And how you make ethinyl estradiol? Where you put ethinyl?
The 17.
Can you show? Do you have that picture of estradiol and ethinyl estradiol? No. Okay.
We can see here, sir. Estradiol is there, so we can put a ethinyl bond here.
Here, yes.
But this molecule is aromatized. This is estradiol.
Yes.
Now levonorgestrel is another. So this norethesterone is a regestrone which we use, trimolute, which is available.
Yes.
So they are these molecules.
So do you use when you want that lesser androgenic activity should be there and more progesterogenic activity should be there, will you use norethindron or norethistrone? No. But when there is a heavy bleeding, you want to have androgenic activity and progesteronic activity both. There you use regestrone or norethistrone. That acts as a potent progesterogenic as well as potent androgenic also. So it gives a better result.
So another group molecule which we use in oral contraceptive pills, we use it in even in LNG intrauterine devices, is levonorgestrel. So levonorgestrel is
what is LNG IU means?
Mirena, which is available, and we use it in emergency contraception also. So this levonorgestrel, it has a methyl group at the 13th position here. It is the same as norethindron, but it has a methyl group at 13th position. So norgestrel has two. It is a mixture of levonorgestrel and dextro. But the dextro part of the norgestrel is weak and it has no activity. So the only activity that norgestrel has is the levonorgestrel one. So norgestrel is the same as norethisterone, but with a methyl group at the 13th position. So this is the 13th position. So first we will discuss this. Now the second, desogestrel and the gestodin and norgestimate. Now they are the same. This component is the same. Testosterone. This one. C111CH and OH. That is the same. That is the ethynyl. Ethynyl part is the same. But then there is only addition of a few more changes are there. Like in desogestrel, there is a methyl group at the 11th, 18th and so this is 17th, 18th. So here there is an addition of methyl group And there is another addition of methyl group here.
Please go ahead.
Yeah. And then there is gestodine. It is the same as LNG, but it has a double bond between 15th and 16th here.
But in every cases, you see there is something is removed from here. That is
Yeah,
19th
19th carbon is
So
not
these are all
LNG.
19 nortestosterone derivatives. So there is no 19th carbon.
Yes.
But now in other part of the molecule, they have created some, attached some other, it is I think 1, 2, 3, 4,
So
5,
this is
6, 7,
13.
8, 9, 10, 11, 13th.
13.
If you keep CS2 and CS3, they have added. And these things, they create more progestogenic activity, but basically they are derived from
Norethindrone.
that is from testosterone originally. So 19th carbon atom is missing.
Even Diagnostic. Diagnostic is a direct derivative of testosterone and not norethesterone. Other progestogens were derivatives of norethesterone, but this is a direct derivative of testosterone. And it has cyanomethyl group at the 17th carbon atom,
Yes.
cyanomethyl group, rather than an ethinyl group,
Yes.
which is there in norethesterone. And then at the 9th and 10th position also there is a double bond. In drospirenone is a spironolactone derivative.
So spironolactone is a mineralocorticoid.
Mineralocorticoid.
So that means mineralocorticoid also derived from the original molecule of cholesterol. That is also cyclopentane of paradoxine. That also derivative from that. And that's analogous spironolactone. So a spironolactone has a steroidogenic activity. If you change something over here, then it becomes a progestogenic activity.
Okay. And last is injectable DMPA, injectable progesterone. That is, it is made the DMPA injection DMPA is used as an injectable contraceptive. So it is made from 17-hydroxyprogesterone, and it is not from testosterone. And there is an acetate group at 17th and methyl group at 6th position. At the 17th position, there is an acetate group, and
Yes.
there is at the 6th position, there is a methyl group.
Yes.
So this is how we use different progestogens in our day-to-day practice.
So can you explain why there is norethistrone, then there is a, can you go behind the slides? Again? No, go ahead. No, go forward. Again? This is, you have shown the different stages or different generations of progestogens? No, these are the next generation.
This is the second generation, yes.
And what is the third generation?
Diagnosis.
Yes, and this is the fourth generation. I think lot of generation has been developed in progestogenic activity. Why companies have developed this? Do you have any idea?
So to reduce the androgenic effects and to increase the progestational effects.
They all increase the sex hormone binding globulin. Whenever there is a sex hormone binding globulin, there will be less free testosterone. When there is less free testosterone, the androgenic activity will be less. So there will be more progestogenic activity. And more the progestogenic activity, better will be the oral contraceptive. So what is the use of levonorgestrel? Why you are not using simple estradiol? What is the advantage of ethinyl group?
So it will make it orally active.
And more potent. So you less consume and better action in vivo. So they put a ethinyl group in estradiol. So it becomes an ethinyl estradiol. Now the ethinyl estradiol is the main, so-called main culprit of thrombosis. So we have a complication of oral contraceptive with thrombosis. How you reduce it? So you have
by
to
reducing estrogen.
Now, I am asking a question. You are a practicing gynecologist. If I reduce the level of estradiol or estrogen in oral contraceptive, will there be a good proliferative phase or less proliferative phase?
Less proliferative.
If there is a less proliferation, there will be more breakthrough bleeding. Patient will bleed more. So at the level, some specific level, you cannot go down. So the contraceptive activity is done by mainly the progestogens. What they do?
Sir, they inhibit the FSH, LH.
And LH, mostly the LH surge and all. So there will be no ovulation. But if there is no ovulation, there will be no estrogen. So there will be less proliferation. If there is less proliferation, there will be
breakthrough
bleeding. Have you noticed any patient that you gave the pill and she complained with that, madam, बीच में bleeding हो रही होती है? So what you do then?
So we increase the dose
Of
estrogen.
yes. Why we are reading this? Why we are discussing? We are not only discussing the chemistry. This is the main thing which we are using in our day-to-day practice. And if you can understand why now, if you go for a lady with hyperandrogenemia, like in hirsutism or PCO, will you want to do, or you prefer to use a more androgenic norethindrone? No. So what is your progestogen then? Because you cannot change the ethinyl estradiol.
So we will use the newer generation.
Yes.
Progesterone.
So do you have any idea what you use in your day-to-day practice for polycystic ovarian disease?
Sir, cyproterol acetate.
No, any brand of
Sir, Ginet 35.
Yes.
And this one, sir.
What is Ginet 35?
It has ethinyl estradiol and cyproterol acetate.
What is cyproterol acetate?
It is
More progestogenic, less androgenic. In the same way, Yasmin came, the drosperinone. Do you use any progestogen for the treatment of endometriosis nowadays?
Sir, 3 days we use. That is Diagnostic.
That is Diagnostic. What is? Have you shown the Diagnostic?
Yes, sir. Yes, sir. Yes.
Why we are studying this? Because you are using this molecule, and this molecule is very important for your day-to-day practice, looking at the hormonal status of the patient and what is the disease. Then only you can choose the molecule. So you have Malati. I have not brought the drugs, but it has ethinyl estradiol and norethindrone. Simple, or levonorgestrel. You are not bothered about whether there is an androgen activity or not. It should be a strong contraceptive. But more you use it with 30 micro or 50 microgram. Previously it was 50 microgram of levonorgestrel, created more thrombosis and heart attacks. So nowadays what they are to 30, and a low dose, I think 20. But you go low dose, it will create more breakthrough bleeding. So if you have that breakthrough bleeding, then what you add into that? What you usually add? Ajay? What estrogen you add normally?
It can shift from 20 to 30.
Either you turn 20 to 30 or you put 2 milligram of ethinyl estradiol value. Simple. That will increase the proliferative phase. So these are not only the chemistry. So I put this topic very important, that it is very useful to go for 2-cell to gonadotropin theory and use the gonadotropin in your ovulation induction. And second, when you choose an oral contraceptive for a young girl, for a just married girl, unmarried, married, obese, non-obese, hirsute, non-hirsute, with endometriosis, with no endometriosis, they all need contraception. But the choice of molecule of progestogenic activity will be very important. Until unless you know these, you cannot choose from the market which to choose. That is the basic fundamental theory behind this topic, and it is a very useful and important. It sounds a little bit scary because there is more organic chemistry and all, double bond and triple bond. But it is not so difficult. If you understand the basic structure of cholesterol, things will be easy. Thank you, Disha.
Thank you so much, sir.
And second talk will be to अपना वो चालू
कि जैसे अगर many times we give
contraceptives before starting ovulation induction or starting the IVF treatment of a patient. So suppose there is a PCOS patient, so we will prefer giving something which is anti-androgen, so that we can decrease the androgen amount in her body, so to get a better result, because giving her overall or Malayan or Malady will cause increased androgen in that patient
Yes,
with a piece. So we
yes.
should be careful. But for a patient, suppose the patient has some patient has low AMH. So for that patient, will the contraceptive with androgen will be better? Will it be better than using something with anti-androgen? Because androgens are also precursors. So will that have that effect?
Because the androgens which are precursor, what we use as a precursor in low AMH is DHEAS and testosterone.
Testosterone.
But it is not in a contraceptive way. One very important thing, Disha, that here दो चीज डिफरेंट है. एक है हार्मोन रिप्लेसमेंट थेरेपी में भी हम यूज करते हैं, एंड वन इज वी आर यूजिंग इन oral contraceptive. Oral contraceptive is used in a fertile woman. I will come to your question. In a fertile woman who is ovulating. So you have to make the level of that drug higher than that inherent estradiol and progesterone. That means you are creating a milieu atmosphere which is in pharmacological dose. You are going above. Now if a low AMH or the question is that what we should do.
Which contraceptive, like if the patient has irregular cycles, many low AMH females have irregular cycles, and we have to, sometimes she doesn't get her cycles on her own, so we have to give an OCP to regulate the cycle and then start her stimulation, or whether it's ovarian stimulation or whether it's IVF, whatever it is.
Yes, yes.
So for that, for a patient with low AMH, then giving an anti-androgen pill will not be necessary. Like we can use the older ones, and they should have the similar effect or better effect, because they increase they give supply some amount of androgen. That I must.
No, this androgen which is not testosterone derivative is not a regular biosynthetically dehydroepiandrosterone or androstenedione. If you give even the pure testosterone gel before stimulating a patient with low AMH, that will help. Now, if you are asking me that if there is an irregular period with low AMH, that is a difficult thing, because if the low AMH is there, that means she is not ovulating regularly.
She is not ovulating.
Now, if you want to have a withdrawal period, then better just use a pure progestogen, that is medroxyprogesterone, which is not androgenic. You can use that with a, but mind it, if it is a low AMH which is creating hypomenorrhea or irregular menses, then chances of getting eggs will be less. Patient should have a regular period if low AMH and you want to use her own eggs and do IVF. In that case, if you want to match the cycle with other patients, or you want to match, you do some, it is better to use than.
Like if we just want to get her periods, many a times the patient doesn't have a period for 2 to 3 months.
It is better
and
to use.
we don't want to wait for that long.
It is better to use a pure progestogen rather than using strong
contraceptive
pills. That will create more down regulation and you will have less
But
eggs.
we also use it for down regulation if the FHS is high.
If FSH is high, that FSH can be reduced, but it will not help you to create more eggs here.
But compared to the one with anti-androgenic effects, like they will have a similar effect then. We did not go for an anti-androgenic contraceptive pill as we need to go in PCOS in a patient who doesn't have PCOS. That other pill will have a similar effect.
No, for PCOS, the theory is different.
No, not patient not having PCOS. So do we have to go for anti-androgenic pill only? Like we make sure that for a PCOS patient, before the cycle, if we have to give a contraceptive,
Yes,
we will go
that's
for
why we give
anti-androgen.
that's why we should give Ginet and cyproterone acetate.
But in a patient who doesn't have PCOS, is it necessary to go for that pill only, or we can go for a simple overall L or pill like
I
that?
will never say go for overall L19 or testosterone derivative pills, because these progestogens are more androgenic, and when we have better progestogens, although they are
So
derivatives.
rather than going for this, we can actually go for estradiol valerate, and then give progesterone for withdrawal. So
Yes.
that will cause better suppression
Better,
rather than
yes,
going
yes.
for
And for that
contraceptive.
withdrawal of the bleeding, don't use norethistron.
Go for medroxyprogesterone, or we
Medroxyprogesterone.
can even use dydrogesterone also.
Yes, there are pills which are using dydrogesterone or drosperinone with ethinyl estradiol. That can be used better in IVF. But for me, it is my view that it is better to avoid stronger
And
anti-androgen.
in patients with ovarian failure, when we are going for a donor eggs and the patient already has ovarian failure, then it is always better to go for pure estradiol, valerate, and then progesterone.
Absolutely. Be pure progesterone. Now, Ashita will go with her very small topic, that is day 3. Should we do day 3 transfer or day 5? This debate is very long standing debate. We support blastocyst transfer, but there are some advantages which she will discuss. And this topic came in Fertility Sterility 2025 June issue. And I ask her to please go ahead.
Okay, so my topic for today is extended embryo culture. Extended embryo culture and IVF. Should blastocyst transfer be the standard of care? So in this article, what they have studied is whether doing a day 5 or a day 4 early blastocyst or day 5 blastocyst transfer it gives better results as compared to a day 3 compact embryo transfer. So introduction, embryo transfers, they have compared 2 timings. One was day 3 cleavage embryo, or we can say compact embryo, and day 5 blastocyst. So what the final result, when this study was published, the trends were all going towards blastocyst transfer. So the question what they have put up is, should extended culture be universal? That in every case should we go for blastocyst transfer or not? So the clinical evidence in 2016, CDC recommended that blastocyst transfers lead to higher live birth rates. That is birth of a live baby. So and Cochrane review also suggested that better live birth rates were seen with blastocyst, but the pregnancy rates were similar. That means that what they found in their study was the patients who were getting pregnant was almost the same. The number of patients was the same. But having a live baby delivered, the rates were much higher with blastocyst transfer than with a day 3 transfers. But one more thing they also noticed, that all embryos do not survive to day 5. So we will discuss this later on, that what is the significance of this sentence over here. So the most important thing which we have to consider in such cases is some important factors such as age. What is the age of the patient? What is her egg quantity? What is her AMH? And then what is her fertility prognosis, or what is the probability of her having a child, and what is the probability of having future cycles also. There are a lot of factors which we have to consider for this. Then the number and quality of embryos, the lab performance, and also most importantly the patient's choice. And we have to avoid a one-size-fits-all policies. That is, we cannot put up a protocol and apply it on each and every patient. We have to make a protocol according to these factors, considering the patient's choice, and then finally decide what should we go for. So the first argument is selection process. So Zio et al. Had said in a study that better outcomes were seen with day 3 transfer when only one embryo was available. And some embryos may arrest in vitro but implant if transferred. So what they are trying to say over here is, many a times what happens that if a patient has low AMH, produces less number of eggs, less number of embryos. So by waiting till day 5, many embryos, a lot of them may not survive. Though it gives us an option to choose which is the best one, but we also may tend to lose those embryos, and sometimes it is seen that these embryos will survive better in a natural environment, that is the uterus. So a person having very low egg quantity, very low number of producing low number of embryos, a day 3 transfer gives those embryos a better chance of survival and a better chance to get implanted. Then the second argument was role of aneuploidy. So when they studied the role of aneuploidy and the importance of waiting till blastocyst stage, so though by looking at the embryo, the quality of embryo can be studied, looking at the size, but the aneuploidy cannot be completely determined by just looking at the embryo. We have to go for PGT. So what they said that during these 30 genetically tested embryos, the blastulation does not slowly link to aneuploidy. That means going into a blastocyst stage doesn't mean that the embryo does not have aneuploidy. So this argument, another argument failed that going for blastocyst gives non-aneuploidy a good quality. Though embryos are good quality, but we cannot surely say that they do not have aneuploidy. They also might have aneuploidy. Then the PRECISE trial, it was an RCT funded to evaluate the blastocyst and cleavage rate, and their target group was patients with less number of embryos. So what they found out during this was that whenever there are less number of embryos and whenever there are more number of embryos, according to the patient profile, patient choice, AMH and age, we decide whether to go for extended culture or not. If we have less number of embryos, then definitely every embryo should get a chance to get implanted. So we can go for a day 3 transfer because some embryos might have a better chance of survival inside the uterus. But when we have a number of embryos, then we have the choice. Then we should go for the better quality ones so that in the first cycle the patient gets the results. And when we have a choice, we should choose the best one. So in that case, going for a blastocyst transfer helps in a way that we know which embryos are going to survive, which are actually progressing to day 5. Then we can select the best quality one, the better growing one, and it will help us in increasing not only the pregnancy rates and also the live birth rates. So they had used this formula that live birth rate per blastocyst upon cleavage more than 1 upon blastulation. So according to this formula, they had mathematically made a model and calculated their results. So the important thing which they have said, the impact of age on blastulation. So this was a mathematical formula. So they have calculated that approximately at age 34, 3 blastocysts, and at age 42, 1 blastocyst from 8 oocytes developed. So according to this formula, if we see that at the age of 42, out of 8 oocytes, only on an average 1 blastocyst could be formed. So this might give rise to a chance where we are losing out on some good quality embryos that might have a chance to survive. I'm not saying that they are going to survive or they are going to increase, but we might lose on some embryos that might have a chance to survive inside the uterus. So, yes. So, yes.
It is 8
Similar.
oocytes
They have
from
calculated for the
8
similar.
oocytes.
So what their inference was accordingly that blastocyst transfer is definitely a better option. But in some cases, we have to consider the patient's age, patient's AMH, and the quality of embryos, and then only decide for going for blastocyst
What
transfer.
I understand, Ashita, with this that for getting 3 blastocysts, you need even 8 oocytes less than 34,
Yes.
or you need 8 oocytes at 42 to get 1
And
blastocyst.
getting 8 oocytes at 42 is a very difficult task.
Thing. And second thing, what they are I think what they are stressing that if it is more age, less eggs, better not to go for strict protocol for blastocyst.
Protocol that we will only do blastocyst. We should give the other embryos also a chance. They are insisting. So conclusion, blastocyst transfer.
And your one of the very important statement that what they have written that if you have plenty of blastocyst on, when you see there are multiple eggs and they are good quality on day 3, and if you have a prediction that they will go to blastocyst more, then we should go for
Then we
blastocyst.
definitely have a choice to choose the best one,
Best one.
out of them, and we will know which will survive. When we have a lot of options, then we have to decide which is the best. When we have less options, we have 2 embryos, 1 embryo, then we don't have a choice. So better do a day 3 transfer so that those embryos have a better chance of surviving inside the uterus.
But the modern day, what is happening, Ashita, that they are also after that 34 or 35 years, more than 35 years, the chances of aneuploidies are more.
Yes.
And if you want to transfer an embryo in more than 35 years, the chances of having aneuploidy in the more. Now the question is, if you transfer day 3, how you can identify aneuploidy in embryo? That is one of the debating talk.
Yes.
So it is a very difficult situation for us also to go for blastocyst, and if there is no blastocyst, you lose
We have to
everything.
cancel the cycle.
So it is the same way that either you do blastocyst and do biopsy and it becomes an aneuploid, you don't transfer it. Or if you have only 1 or 2 day 3 embryo which are good quality without doing PGTA,
Take a chance.
take a chance and then
That
do.
is what they have said, that blastocyst transfer is better for good prognosis, young, many embryos. But cleavage transfer is safer in lower responders to avoid cancellation. So we have to use logical and individualized approach. So take home message, extended culture selection tool, not a treatment. Don't discard day 3 embryos prematurely and let the patient profile and lab metrics guide the transfer.
I think, Ashita, it was a very good paper and little bit thought-provoking. Please come here. And कई बार ऐसा होता है कि जब आप IVF करते हो तो आपको IVF में ये वाला प्रॉब्लम जो अब फेस मैं कर रहा हूँ, that is the evidence based is that they must have failed. Then you have to that if you don't get a blastocyst, then transfer will be cancelled. So this is a very thought-provoking paper, and we can always discuss about with the patient. I think we should clear with this idea to the patient that what we are doing. So we have 2 talks today, and this is again beginning of this journal club. We will continue with Disha and Ashita, and I request other people to join us. If they want to join us, we can keep the topic every 15th day. We will take journal topic from white journal, that is ultrasound OPGY, fertility, sterility, human production, and prenatal diagnosis. And if you have any topic, from anywhere, please come with it and we will do it. Thank you, Disha, and thank you, Ashita. Thank you very much.